video, I'm going to show you two cases of classical Spitz nevus. These have been kindly shared with me by Dr. Antonina Kalmykova of CSD Healthcare in Kyiv. And they're both lovely examples, and I think it would be useful to look at these carefully and form some baseline ideas as to how we approach Spitzoid lesions. I'll talk about atypical Spitz nevus or atypical Spitz tumor and Spitzoid melanoma in a different video. So we've got multiple cuts of the lesion, so let's have a look at these two in the middle. We'll just enlarge it slightly, and we need to turn it round obviously because it's upside down. There. So let's have a look at this one to begin with. Now the first thing you need to do with any melanocytic lesion, but particularly in this context, Spitz nevus, the two things you want, well, there are three things you can do at low power. The first is assess the symmetry. The second is assess the circumscription or lack of. And the third thing is to look for evidence of maturation with depth if it's a compound lesion. Now this lesion is mostly junctional, but there's quite marked pseudoepitheliomatous hyperplasia, which is not that uncommon in the Spitz nevus, but it can lead to a rather confusing appearance at low power. So to assess symmetry, what one does is one drops an imaginary line from the top and draws the line down through the lesion through to the bottom, and then you compare the left side with the right side. And in this cut, I think the lesion shows very good symmetry. And then we look for circumscription, which is essentially to see what there is at the edge of the lesion. And this is a bit difficult with this particular one because it's presenting as a polypoid structure, which is not, it's not uncommon, but it makes it a little bit difficult. But we can see nests there at this edge of the lesion, and I think we can make out nests at this edge of the lesion. So if we compare that bit with that bit, I think we can see that it is well circumscribed. Now, at this magnification, we can't really make much of the dermal component. It's not very obvious, but we'll see that when we look at it later. So at this stage, we know we're looking at a melanocytic lesion. It looks Spitzoid, it's symmetrical, and it's circumscribed. So those are all good things. Now we'll magnify it up a bit now and see what else we can come across. Well, there are some useful features. The junctional component shows retraction artifact. The nevus cells have retracted away from the adjacent epidermis, and that's a feature of a benign Spitz nevus. And then secondly, we can see that the nests are broken up there. It's a discohesive melanocytic population, and again that's a feature of a Spitz nevus. So that's two good features we've seen. And then the other thing that we can notice at low power, the presence of all of these blood vessels that are dilated and stuffed full of red cells. And telangiectasia is not uncommon in a Spitz nevus, and it's why it sometimes appears red clinically. So let's have another look at higher magnification again, and we can see the discohesion. We can see these dilated blood vessels, and then the next thing we want to do is to have a look at the cellular population in a bit more detail, and we'll magnify this up to full magnification. And we can see that the nevus is composed predominantly of spindle cells, which is not uncommon, with abundant cytoplasm and with round or oval vesicular nuclei with one or more small eosinophilic nucleoli. And something else we can notice in this field is this eosinophilic body here and this collection of them there, and as you know, those are camino bodies. They don't necessarily distinguish between Spitz nevus and a Spitzoid melanoma, with the caveat that if you have multiple camino bodies, that is said by some to be more in favor of a Spitz nevus. I'm not sure I have any views on that at all, really. So let's look at this population. So we're looking at the top, and as we progress along the lesion, we can see that looks like a dermal component there, though it's hard to make out. And then there's a very heavy lymphocytic infiltrate. And if we look at the other, this is actually better here, because we can follow this down. So there's a junctional component, and that's becoming dermal, and that's definitely dermal, and that's definitely dermal. And what we're looking for is maturation with depth. And when we talk about maturation, what we mean is the nest size gets smaller with depth, as does the cell size. So let's look at that a bit closer, or we'll look at it at high power. So that to give us an idea, there's our surface. There are the large nests at the top, and as we work our way down, we can see the nests are getting smaller, and the cell sizes are obviously much smaller. And so we do have maturation with depth. And there's a possible mitosis there, somewhere near the epidermis. Whether that's junctional, I'm not sure. There's another one there, but I don't know whether that's in a keratinocyte or in a nevus cell, because there's obviously very marked epithelial hyperplasia. There's another one there. So there are lots of mitoses, but they're all at the top. There's another camino body, and there's another camino body there. That might be a mitosis there. And there's another one there. So there are quite a few mitoses. But as we move our way down, all being well, we won't find any deep mitoses, because if we find deep mitoses, then we have to be a bit more careful with it. But no, I think all of the mitoses are up at the top. So that's one case. Now I wanted to show you a separate case, because it has different features. I just have to make sure I get the right one. This is the one I wanted here, yes. Now, I don't have clinical histories for either of these cases. I think with patient confidentiality and so on, it's probably in the best interests, unless it's really critical, not to give the age of the patient. But it would be reasonable to assume that these came from young people. Anyway, so here's the second case, and we've got two cuts of it. Unfortunately, there's quite a lot of artifact, but one just has to live with that. Now, I wanted to make another point to you about maturation, because maturation is two things. Maturation, sorry, I'll go back to low power again. Maturation is, or sorry, not maturation, symmetry. Symmetry means that the left side matches the right side, and it's quite hard to tell on this lesion because we're missing so much of it. But what we can do, and it's quite useful, is we can look at the top, and then we can compare left and right. Let me just straighten that slightly. There, that's better. So there's the top. And what you can do is you can work your way down and look at the left side and the right side with depth. So at equal levels in depth of the lesion, left and right should look the same, which I think they do. And as we go further down, the nest size on the left and the right is the same. And this field here shows us, yes, there is maturation, because we can see that the nest size gets smaller with depth. And I'm not sure about the cell size. We better go up to the top and have a look. So that gives us an idea. That's the size of the cells at the top of the lesion. So they're quite big. They're spindled, as with the other one. They have fusiform or vesicular nuclei with small nucleoli. And then as we work our way down, we'll get to the bottom. And I think, yes, the cell size is smaller with depth. So we have maturation. So now, having looked at that, I want to show you a couple of special stains that we did on this case. The first one is going to be P16. And let's have a look at that. I need to turn it around a bit, and we'll enlarge it now and have a look. And I'm not sure how useful P16 really is. I think it's useful when you know the diagnosis and it confirms the diagnosis, but when you're not sure whether it's a nevus or a melanoma, I think it can lead you up the garden path quite easily. So let's have a look at it. So at the top of the lesion, we've got some P16 staining. As we work our way down the lesion, again there's some. Some cells are positive, some cells are negative. Let's have a look at the other piece of tissue. That was that one. See if this one shows us anything different. Well, I don't know what to make of that, really. There are positive nuclei and there are negative nuclei. And in fact, the interesting thing is perhaps it's more brisk at the bottom. And if you wanted to make that in favor of, it's getting a bit more juicy there, isn't it? I think if we use this field as being indicative of the lesion as a whole, then I think one could say that there's fairly brisk P16 staining. So that would be in favor of a Spitz nevus. Now, what else? I've got two other immunos. Gosh, I've forgotten what they are. I think this one is, let me just see. We'll just have to turn it around and look at it in close up to see what it is. I think this is key 67. So yes, it is. So we're looking at key 67 expression, and there's a lot of expression in the epidermis because it's showing reactive hyperplasia to the presence of the growing lobules of nevus. If I go down to slightly lower power, that's probably better. And what you can see very clearly there, in fact this is absolutely lovely, is that keratinocyte shows marked key 67 expression, and the nevus pretty much shows nothing from top to bottom. So that would be really good, and that's a strong indicator that this melanocytic lesion is not doing anything that should worry us. If we did a cyclin D1, that would also be useful, and we didn't, but I'm assuming if we had have done it would have been -2. But that's as good a negative key 67 as you're likely to see. Lymphocytes sometimes take up key 67, and that could confuse the issue because then you're not sure what's positive. But it's quite interesting. There are a few lymphocytes in that cluster there, and the odd cell here and there, we don't know what those are, but they're probably lymphoid cells. But it's very obviously and strikingly negative. And let's look at the other immunohistochemistry, which is this one. I think this is HMB45, but I'm not absolutely certain. Let's have a look at that now. I have to straighten it first. And there are two bits, so we'll look at the top one, which looks pretty clean, and then we'll look at the other one. Well, we can see there's expression in the melanocytes in the epidermis, but there's in this piece of tissue, it's pretty well negative. There's a little bit of expression there, but we're really looking for cytoplasmic expression, and there's a little bit there and there, but there's not a lot. And as we work our way down, I think I would regard that as pretty regularly negative. So let's look at the other piece of tissue now. I've got to see how I get back to it. There's the other bit there, you see, and this unfortunately is very dirty, but it shows the same thing. So there, the keratinocytes are showing HMB45 expression. And then there's all this sort of background stuff. I'm not sure what's going on there, but the actual nests of nevus cells are negative. So if we summarize this second case, we weren't able to sort out whether it's circumscribed or not, but we did think that it was symmetrical. We did think it matures with depth, and actually that HMB45 is quite nice because it shows you there's a lovely sort of a pointed base where the cell size and the nest size are clearly smaller than those at the top. So we know it matures well with depth. We didn't see any mitotic activity in this one. HMB45 was negative, as was MIB1. So I think these are both classical Spitz nevi. Now you might wonder about the mitotic activity in the first one, and my thoughts about that are, firstly, they were all very superficial. Secondly, it was uncertain which ones were melanocytic and which ones were keratinocytic, because there was a lot of pseudoepitheliomatous hyperplasia. But what was important was we didn't see any deep mitoses, and the lesion was symmetrical, circumscribed, and matured with depth. And that being the case, I think we don't need to worry about it. Features that you should look for in a Spitz nevus that we haven't discussed really are cytological. One needs to look for evidence of something else going on. For example, one might find some expansile nodules in the dermal component. That would be worrying. One might find marked nuclear pleomorphism. That would be worrying. Spitz nevi, particularly epithelioid Spitz nevi, they are pleomorphic by definition, but the pleomorphism, if you like, is a sort of a uniform pleomorphism. All the cells look similar, whereas in a malignant process, the pleomorphism would vary very much from one cell to another, so they'd all look different. One looks for the presence of deep mitoses. That would be worrying. One looks for the presence of atypical mitoses, and that would obviously be of concern. And then lastly, we might look for lymphovascular and perineural infiltration. Perineural infiltration is a little bit, you've got to be careful with that, and I'll talk about that when I discuss some cases of atypical Spitz nevus and Spitzoid melanoma. So I think that should be enough to keep you going, and you may want to watch this video a couple of times because these are really two nice cases, and if you watch them carefully, I think you'll see all of the features you need to assess when you're looking at a Spitz nevus, and then you can compare these cases with one that you're worrying about. So thank you very much.